All right. So this is our last panel of the day. A very challenging topic, at least for me, not being a finance expert. So we're really looking forward to hearing perspectives from different speakers with different backgrounds and thinking through this topic. Rachel Nugent will be moderating this session. Many of you already know her, but she's a senior technical advisor at RTI International. And just last year, she retired as the director of the Center for Global NCDs there. She has 30 plus years, 30 plus years experience um, in the global development sector as a researcher, practitioner, and policy advisor to governments. And she led the Lancet Task Force on NCDs and economics in 2018. She has a lot more experience, a lot of other things I could say about her. But thank you so much for chairing this session, and I'll hand it over to you.
I'm going to walk up here so it'll stop you right there because your voice is scratchy. Huh? Wonderful. Great to see everyone here and the end of the day. So we have to be lively also to keep me awake given the jet lag thing. So thank you for coming back, everybody. We have a really experienced panel and we have a lot to talk about, but I think I'll just do a quick introduction. And then we have 3 people online. We're going to start with them and then 2 people very fortunately who are in the room with us. So what is this panel about? Sylvia always says, I'm not an expert on financing. And with the word financing in the topic, people always expect me to get up and say, well, here's the money and here's how you get it. I've probably been asked to do that 500 times. And I never do. I never deliver, especially the second part. How do you get it? So I don't know why I get invited for any of this, but it's not that easy. I think we know that. And so there's a lot of different aspects related to financing or even really more broadly the economics of this. Even just this morning, I think we talked about costs and we talked about oligopolies and monopolies. We talked about prices. We talked about insurance. All of that kind of comes into play when we put in the word financing. So it really isn't just as simple as where's the money. So that's a kind of a caveat. Don't expect an answer to that. And I don't think you really do. But we have a panel of speakers who have really experience in funding NCDs, facilitating funding, seeking funding, and a wealth of experience in humanitarian settings. So I think it's the perfect combination. I am the least experienced. But nobody really specializes in financing NCDs in humanitarian settings. Just like 20 years ago, nobody really specialized in the economics of NCDs, which is sort of now I can say I know that field because I've spent 20 years doing it. But financing NCDs in humanitarian settings is really not a well-defined field yet. So I think what we're going to be hearing among these panelists is a variety of views, some of them very strong views, and probably some of them that I wouldn't agree with. And I think that's great. And by tomorrow, when we have our workshop, we'll all agree on everything, right? That's when we'll really coalesce. But today, I think you're going to hear a range of different perspectives, which is really what you should hear. So let me just get started. So as I said, we're going to start with the folks online. I've asked Austin and Laura to stay seated for a bit so that they can watch and listen, and then we'll bring them up. And we're going to kick off with not exactly a lightning round, but I'm going to pose a question they've all heard already, and I'm going to ask each of them to give us an answer. Could be quick, could be a little more extended to that particular question. And the question is the following. Which of the following is the biggest barrier to NCD care in humanitarian settings and how to solve it? Small question. Is it insufficient funds? Is it institutional silos? Is it a lack of technical capacity in NCDs or in humanitarian settings? Or is it a low priority for one or both of those things? And before all of you say, it's all those things, or it's none of those things, or anything, we're going to hear from our speakers. And I think they're going to give us different perspectives and different answers. So I'm going to turn first to Linda, because she may have limited time with us today, and we don't want to lose her before we hear from her. And Let me just scroll here. I have these fantastic bios, but I'm not going to read them. So sorry. We can send them to you after. But Linda has very extensive experience in international health and humanitarian sector. Many of you may know her. I'm going to shortcut this. Linda is in the role of the Global Health Cluster Coordinator that she has been in for since 2014, and so is responsible for overall WHO leadership, under WHO leadership, for coordination and strategic direction of partnerships for humanitarian health action. So that's all I'm going to say, except Linda, you've got the kickoff question, and then after everybody has a chance to answer that, we're going to come around with some targeted, moderated discussion. So over to you, Linda.
Okay, thanks very much, and thank you for the invite to be with you today. So I'm going to say, in response to your opening question, I am going to say all of the above because it's very context specific. But as the health cluster in the field, what we're there to do is to help coordinate and support the delivery of assistance to populations in need. So my concern is that we have the capacity to deliver the services, but also that those services are financed. So maybe just to say, how do we finance health cluster activities? Well, that's largely done through a humanitarian response plan. We do a detailed analysis, the public health analysis, to define the level of health risk and vulnerability in the population. And very frequently, non-communicable disease will come up as one of those key risks, either high, medium, or low, and diabetes within that. And we designed a health service package that all the cluster partners will deliver to write that public health situational analysis. That package is presented as costed and is incorporated within the overall cluster response plan. But we then have to seek funding for that. Now, to do that, we have to present the cluster plan to the humanitarian coordinator, OCHA, and the donors and say, this is the scale of the health need in this humanitarian crisis. Here are the priority activities based on situational analysis. Here is the package. This is how much it costs. You need to fund us. But we have to defend that against all the other sectors: food, nutrition, food security, education. So just because I think it's my team think it's a priority, and it may well be the priority, everybody in the other sector thinks theirs is a priority too. Now, it is not unusual for the decision to be, or the response to be, well, that's all very nice, but we don't have enough money to cover either health or the response. So please go back and cut the funding and reprioritize your response. Those decisions do not sit within the control of the health sector. We have to follow the advice that is given, either by a donor directly or by the humanitarian coordinator or whatever. So we have to go back and reprioritize the package. And we will then say, okay, NCDs, diabetes within these situational analysis, is it high risk, medium risk, or low risk? And we will have to make decisions on the package, revised package content on the basis of that. These are difficult decisions, but somebody will miss out. The other issue we're facing now is what is called boundary setting. What is considered a humanitarian health activity and what is not? And if it's not a humanitarian health activity, people imply by that is this is regular health system support, this is part of a national disease program, so why are the humanitarians dealing with this? So this is another, we have to look at it context specifically. So look at Ukraine. For all the difficulties Ukraine is facing, the health system is functioning there to a highly constrained, but in the majority of the country. There are very specific parts of the country where it is not, or it's highly, highly constrained or there's limited access. What the cluster has done with the Ministry of Health there is work with our colleagues who on the NCD program and agree which aspects of NCD support the cluster will include in our package of health services and will deliver in these highly inaccessible, insecure areas under the humanitarian response plan. The rest is being done through the regular health system. So we were constantly having to defend the need to include NCDs in the health package. We're constantly having to defend why that is considered humanitarian versus health system support. This is an ongoing debate, and it often means that somebody will lose out. Just to put this in context, as of now, 70% of the 30 health clusters that are currently responding to humanitarian crisis have received less than 10% of the funding requirement they have asked for under the humanitarian response plans. So on a daily basis, we are making difficult decisions about the scope and scale of care. So my question back to you, as the experts in diabetes and NCD more widely, is, does the issue sit with the humanitarians, or is this really about decisions by government and or donors who fund the health system to be more resilient in their ability to respond to crises when they occur and to repurpose their resources?
Thank you, Linda. And thanks for posing a question to the group. I hope we can get to that. I'm going to come right back at you, and then I'm going to turn to Saeed, and I'm going to come back at you to tee up a question for you, perhaps, assuming we have you still, to come back to as to how we might. I mean, what I heard had to do with silos that you struggle with, as well as some of the things you pointed out. So, are there other sectors that have managed to attain systematic consideration of their needs within the HRP and cluster process, and how should we be thinking about doing that in a more systematic way? So I'm going to leave you with that thought, if you don't mind, and I'm going to turn to Saeed, who is in Yemen, lots of experience with the Yemeni healthcare system, including being the first director of the NCD division within the Ministry of Health. So that was a very lonely job in many countries, and perhaps still is in Yemen. He has a clinical background, and he has over 12 years experience with the healthcare system in Yemen, and has developed a lot of national protocols. So we're not seeing you yet, Saeed. I hope we can hear you. And I'm going to ask you that same question about sort of which of the following is the biggest barrier, if you want to point to one of those things and speak about it, and how you might address it. Over to you. Great.
Hello, it's nice to be with you. I'm Dr. Said from Yemen, and I'm sorry for unstable internet connection. Actually, it's a very lonely job, as you said. Being in NCDs and the first one to lead NCD in a country that the health system is focusing on the inequalities and nutrition and other things that was breaking Yemen. You know, we know that we have a lot of mortality in the past regarding malnutrition, chronic diseases, maternal neonatal. But we wake suddenly and find that the major cause of death in Yemen now is the NGT. We are like any country in the world. And when I started my job to establish a NCD program, we was in the middle of conflict. We was in prolonged, protracted emergency conditions. That was between 2020 when we have also COVID and that but the whole hospital, all services, especially the you know the non-communicable disease services, essential services, have been because in entire 2021, this process, uh, when we go to donors, we find this problem. This NCD is it humanitarian? No, it's difficult and it's frustrating because we have a lot of NCD patients that not receiving, for example, insulin. They have complication, dying. We have like unexpectable number of EQs, hyperosmolar glucose, regardless of the complication that is occurring. For example, the patient that we have sessions, they going to be in a row. They would be a disaster and large mortality. So it was challenging until 2022 when we have this meeting, Cairo and Emerald region, and really the ANC region is and the vote of 20 there. an honor to join that high-level meeting in Cairo. And since then, we have a lot of things that help us in even human context. We have this, for example, February 20, we have this framework and policies that has been released from WHO regarding the human setting. We have the integration of NCD in the emergency and disaster response, cycle. It was a lot of job that we could see that we try to integrate in Yemen. We try to replicate what team other humanitarian working organizations doing and make it clear that sometimes our interventions, in NCD, it's really a life saving. It's humanitarian. The country doesn't have the resources. The like in Yemen, more than 50% of the health infrastructure that was already in 2050 is destroyed. Like, we have one of the largest displacement that push a lot of stress on the remaining uh, facilities. All of this has a very bad and disease outcome on the NCDs itself. So the main job was how to reach and respond to humanitarian and try to do some not sustainable developmental projects, but we want to start the process saving the life of people while thinking how we can continue the service delivery in intermediate term. So it's really challenging because of experience a lot of donors and a lot of you even international charities, they might not consider NCDs as a priority area, and it's really a problematic for us. But by doing a lot of tactics and a lot of and involving multiple donors from multiple organizations and integrating this the minimum service package all of this is help a lot the in, in so that's my short explanation of the situation. I'm very opening if there is anything regarding Yemen and, to ask about and ask about our experience. I know it's humbling, but I think we should consider it as because of the situation that we think that achieved to all hard work of the Yemeni government, its international donors, UN, and even the non-government.
Okay. I hope we didn't lose him. If you can hear me, Saeed, thank you. That was perfect. And we will come back to you. I think I heard about silos again, and I heard about prioritization challenges, but I also heard some very positive. Oh, I hope that means we didn't lose him. I heard some very positive things about the technical support from WHO, the advances through some meetings and gatherings in EMRO and elsewhere, and that you feel integration and some of the other moves are helping. So I hope we can hear more about that in particular. Maybe what has been successful in terms of specific financing streams or sources, and how others might get some lessons from that. So let me turn. Hoping you heard that. We'll come back to you. Let me turn now to Sonia, who is also online. Hi, Sonia. Fresh early morning in DC. So thank you for joining us. And you, well, I've got to say something about you here. Sonia is at USAID and is the, sorry, I'm scrolling to the right spot. Senior, to get your title, Senior Health Advisor for USAID's Bureau for Humanitarian Assistance. Lots of you probably have interacted with the Bureau. And Sonia has a lot of experience in many, many countries, and has served on the COVID-19 task force as well and interagency groups. And thank you for being here with us. You heard my question sort of for the lightning round, if you want to pick one of the sort of, biggest barriers and speak about that, or if you want to reject that whole concept and speak about multiple ones, please go ahead. Over to you.
Thank you so much for having me. I hope you can hear me well.
Yes.
I will have similar thoughts as Linda, and I can build upon her thoughts. And I think that, as you mentioned in your opening, there are many barriers. And I think it's really important to understand how humanitarian donors fund, as Linda said, through the HRP. And I think, we fund, it's important to understand that system, and that funding through health is through that humanitarian system. And why is it so? Why do we not fund governments directly? And that's to try and maintain humanitarian principles of neutrality, impartiality, and independence. Oftentimes we work in highly contextualized places, as Linda said, in that governments are party to a conflict. And so communities that we work with may not feel comfortable receiving services through those government structures. Some examples we have are Northeast DRC during the Ebola outbreak, and in general. And humanitarian health actors and humanitarian actors in general have worked years to gain the trust of the community and work very strongly with communities to have that community engagement. And so, it's really important to remember that. And I think, that really plays into, the fact that we are trying to do something that is very different from, what development and global health does, which is health system strengthening. And I think there are other challenges, as well, as Linda mentioned, priorities and, what we may refer to as rationalization of care. I mean, I think it's well known that humanitarian funding is not increasing. In fact, it seems to be decreasing. And, we have hard choices to make and tough decisions to make. And, as Linda said, we are looking through a variety of sectors, not just health. And when we fund for health, we don't parcel out the different activities in health. So, it's not, the way we fund is not like X amount for NCDs or Y amount for reproductive health, or, Z amount for child health. It's one pot of funding for health, and we really rely on the health cluster partners to decide what those priorities are within health. And based on evidence, we know that the majority of mortality and morbidity is in vulnerable populations, which are women and children. And we also know that those evidence-based activities, such as targeting, diarrhea, pneumonia, and malaria in children, acute malnutrition in children, and having safe places for women to deliver, are where we are able to do the most good for the most people. And so, that is a public health approach, which, may, lead to, a rationalization of care, because we're not going to be able to fund something like cancer care, for instance, which is quite expensive and supports a very small or limited population. Whereas we know more lives could be saved treating children for acute malnutrition, for instance. I think the other thing to mention is that there is a very big donor that has just recently entered, what they call fragile settings, which, I think is quite different than humanitarian settings, but and that's the World Bank. And the World Bank doesn't, they're funding services now in South Sudan and in Yemen, and in Central African Republic. And oftentimes they will fund through governments or, outside of the humanitarian system. And, it's not very clear to humanitarians how their priorities are determined, but they do support elements of a basic or essential package of health services. And so, a solution I guess I'm offering is it would be worth having a conversation with the World Bank to understand how it prioritizes the elements of NCD care within that essential or basic package, and how it's included and what level they will include. Because I think what is so great about the World Bank is that it can transition from a crisis setting into a development setting. That funding is going to be there. The World Bank will be there, whereas humanitarian donors, for instance, and humanitarian system, quite frankly, we don't want to be there for the long term. We are stuck in some of these crises because of the situation. However, we really would like to hand over to a more sustainable donor like the World Bank. And lastly, I just want to mention that the challenges, they're also operational where we work. I mean, in terms of access, it is really difficult to access populations due to security restraints, and other considerations, and then supplies. I mean, we're seeing this right now all over the world in that supplies for all health activities, all humanitarian activities are difficult to obtain due to security issues. And just, for instance, getting those things across a border or, having those things delivered safely across the sea. I mean, there are many, many operational challenges, I think, which need to be looked at before we say that, there's just one or two issues that are affecting care. I'll stop there. Thank you very much.
Thank you very much, Sonia. So I heard, I think, again about some verticality, and perhaps that's not necessarily a bad thing. There are good reasons sometimes for that to happen. And so maybe when we come back around to you, we can contemplate together, you know, what funding streams are fit for purpose for what needs and how they can be coordinated, perhaps, or as I mentioned to Linda, perhaps systematized if it's thought that they aren't now in people's experience is sufficiently systematized or predictable or something of that sort. So maybe we'll come back to that discussion. So let me turn now to folks in the room. We have Austin and Laura, and I'll invite both of you to come up to be in front of our audience here. Thank you, everyone who is online. Don't go away. And I'll introduce Austin first and then ask him the question, and then we'll turn to Laura finally. So Austin Davis works with the Global Health section in NORAD, the Norwegian Development Cooperation Agency, as well as the Bergen Center for Ethics and Priority Setting. So priority setting is a big topic for him. He also has a lot of experience in humanitarian settings, including years with MSF and with UNICEF and the Norwegian Refugee Council. So he is similar to the rest of our panelists, very experienced in a range of these important issues for us. So Austin, you know the question. What's your answer?
Yeah, I guess I'm expected to say all of the above. I'm not going to say that, actually. I'd say there's one thing that's not on your list, but I think it's the most important one, and that would be equity. If we lived in a world where all the states had a reasonable public offering on health and everyone got diagnosed and treated reasonably within their affordability, and then when there were crises, the international community rushed around to help, it would be a no-brainer. There would be NCD packages in every single response. It's because there are very, very differential levels of healthcare systems as a background to crisis that it becomes a very, very troubling question. So the second priority I would put in is technical capacity. If we are unable to get both the data but answer a series of questions about priorities, opportunity costs that nobody's talked about today. And I'm sorry, you guys, you do not understand public financing. You have no clue about public financing, either aid financing or domestic financing. And that's really, you're doing your job, but you're not converting your message because you're not hitting our buttons. So if there was the technical capacity to make the right arguments, then that would again follow up with more capacity, more willingness, I think, to do this stuff. But let me just say, I think humanitarian action is not just humanitarian action, and development action isn't just development action. I like to think of humanitarian action as a political intervention, and development intervention as an economic model of thinking. I think the World Bank stuff that we just heard about is in between. I think it means that there is no nexus. So just I'll be, that's what you said. I worked for MSF. That was poor old Lars had to admit that he worked with Novo, and now I was going to admit that I worked with MSF because everybody seems to have worked with MSF. No, well, yeah. The problem is that MSF is in such a unique position. It's so different from everyone else, and you have to, and they should use that difference to power forward and make innovations. But at the same time, it means it's very difficult sometimes to translate messages. Anyway, I think humanitarian action was very different up until the end of the 80s. We've been in a period of humanitarian action from the late 80s, and I would argue to about now. Our technology in the last 30 years has largely been intervening in very, very poor, low-income states, post-colonial states, with a kind of technology that is about transport, logistics, and a very small set of interventions. Made perfect sense. I think the problem now is that humanitarian era was characterized by two things: a unipolar world with liberal states, and secondly, HIV. I think that both of those have gone. I think that COVID killed the idea of a global strategic Geneva-centered development assistance for health program. I spent the last 4 years arguing, mainly with WHO, that even if there was support and money for a global fund for NCDs, it's not the answer. I've heard it again here today. I spent years of my life trying to dissuade people that would be the right mechanism. People talked about today about global procurement pools, a la Gavi and Global Fund. It would be a disaster. It would be a disaster. Those things do not allow transition. No country uses domestic finance to buy from those pools. It is an answer that serves the interests of donors. It's dead. It's not the model to replicate. So I think we are moving into a much less settled world with a lot of political difficulties, and we've seen the disruption in the Middle East. So we've seen not only Yemen, but Sudan and Libya and Bahrain, and we've seen Gaza, and we've seen Syria, and we've seen Iraq. We probably wouldn't be here with much data if we weren't operating in those environments now. We were still predominantly in sub-Saharan Africa. I don't think MSF even wouldn't have much diabetes data. You're responding to a new set of problems, and those problems are going to get worse. The instability in the Middle East is significant. The populations are aging. Diabetes levels, amongst other NCDs, are spiraling. And that's happening. And that's going to happen in sub-Saharan Africa as well. And it's happening in Asia. So the needs are going up. Unfortunately, the alliance that drove the old humanitarian era is not going so well. And so we're seeing this collapse in financing. I hope it's not forever. I really hope it's not forever. But development finance as well is in a critical state. The countries post-COVID, rich countries are doing pretty well. Poor countries are doing really badly, really badly. And IMF is pulling debt money out of sub-Saharan Africa. IMF is sucking money out. They've aligned their investment cycles with private money in. So when private money goes in, public money goes in. And when private money comes out, public money comes out in debt. Development financing is in crisis. And we're seeing an era where there's virtually no Western investment or interest in Sudan or in Haiti. The only one maybe with a little bit is Gaza, and that's because it's political. It's a band-aid to a broader failure of political responsibility and not knowing what to do about the West's relationship to Israel and Iran. So I don't think it's going to go particularly well. I think I really hope we manage to reestablish a humanitarian collective or platform from which to finance better. It's a moral failure how little we're doing in some of these environments. Maybe I should stop
I
there.
think
Should
you
I?
should. I think you should.
Yeah.
I was hoping he'd be
Could you-
provocative, but maybe in the next round he can be.
All right.
Um,
I'll try and think of something you don't agree with.
I'm gonna, yes.
When she said there's things she might not agree with, she meant me because we were talking at lunch.
We could have a good debate up here about some of it, but I think we all could. So, Austin, when I come back around to you, I'm gonna challenge you to put the words in our mouths, our collective mouths, about what should this group be saying to answer the kinds of questions that public finance and perhaps private finance, but especially public finance decision makers will have. So that's your challenge for the next round. So over to Laura. A lot of people in the room know Laura, I think. So Laura is with International Rescue Committee and leading the health technical unit, leading the monitoring and evaluation health unit for IRC. Has been working in many humanitarian settings for a long time. And I'm going to turn it over to you. You know the question, Laura.
Sure, thanks so much. So I come from a pretty similar, I don't know, background, but I mean, I think that I would say similar things to what Sonia said and to what Linda said. I mean, I think that I kind of have a similar perspective. But I guess, yeah, you went, yeah, it's everything you said. Yeah. Um, yeah. I found it very interesting what you said. I don't just disagree, particularly the last part of what you said. I don't disagree with. I guess I would say the framing, I would say all of the above, but I guess I would simplify it almost by saying something different, which is I think the fundamental challenge is just people living in humanitarian contexts have extremely complex and diverse needs. And it's extremely hard to meet all of their needs. And that's the fundamental issue. And we're talking here about one group with with like a specific set of needs, and those needs are extremely important for those people. But there's just a lot of needs. There's just a lot of needs that people have. And I was on a panel a few weeks ago about the sphere standards and asked to kind of reflect around the evolution of them and whether or not we're meeting them. And we're not meeting them at all. I mean, there's no way that we're meeting them. And again, it's because it's just the complexity of people's needs. I mean, people need so much to survive and thrive. And it is so hard to do that within Sudan, within Gaza, within Yemen. It is so hard to meet their needs. And so to me, that's like the fundamental issue that we have. And so we have to prioritize what needs we're going to support. And oftentimes adult health care is deprioritized. And that's what I see as more of the issue, right? Is that we prioritize women's reproductive and maternal health, and we prioritize children's health. And I mean, I think for many partners, like for IRC, we are committed to the integration of NCDs within primary healthcare. We've really expanded the integration from 6 countries in 2016 to 33 countries, I think, in 2023. So like we are committed to it and we are doing it, and we can see, we see the data to that this is feasible and effective, all of that, but we're still not meeting their needs, right? Like I had a little period of embarrassment. I think your name is Saad. I'm not sure but the story about Pakistan, right? About like the big NGOs who just didn't address the needs of people living with type 1 diabetes. Like, I bet that was us. I don't know, but I bet it was us, right? Because I know our teams, right? And I know that they probably looked at the main causes of consultations, and they just prioritized whatever the top 10 was, right? They prioritize diarrheal diseases, they prioritize acute respiratory infections, they prioritize antenatal, like that's how they prioritize. And it's not that they didn't think that the lives of the people with type 1 diabetes mattered. They just made other choices based on a public health approach. And that to me is the challenge.
All right. Well, if this isn't discouraging enough, let me just.
We are doing it, right? Like partners are doing it. We are trying really hard to do this. It's not that we're not doing it. It's just we're not going far enough. And I think this is a really good forum that like has pushed me, right? But we have to go farther, but it's just really far.
Perfect. That's where I want to go. I want us to drill down some more on what is happening and what should be happening from the point of view of financing. There's lots and lots we can talk about here, but we'll try to actually use the word finance and money and spending and stuff as if we can here. And I want to, this is the sort of discouraging part, I want to just point out that ever since the Abuja Declaration for Sub-Saharan Africa, very few countries in Sub-Saharan Africa have met the goal of spending for health from their domestic health finances, and quite a few of them now have lower spending than they did when the Abuja Declaration was put in place. And that is not only true of Sub-Saharan Africa. So and then of course we are well aware of the international situation. So it isn't getting easier. I think as all of the panelists have spoken to, it's not getting easier. So we have to be more clever. We have to be tactical. I think Saeed could talk a little bit about the tactics and tricks. He didn't say tricks, but I think there must be tricks that have worked in Yemen. And let's hear a little bit more detail about opportunities or at least discussions and dialogues that need to happen. Because I do think a forum like this and other dialogues will be really important in helping us traverse this really difficult territory. So I'm going to come back to Linda here first. And you know what I asked you, but you can say what you want.
Okay, are there silos? Well, inevitably there's always silos, but let's be clear, from a cluster approach perspective, not only does health define where its needs and its area of operation, target population based on a public health situational analysis, we do an a joint intersectoral analysis with other clusters. So again, to further refine and hone down on the population most in need and the combined severity of those needs. And again, this is something we are required to do within the way that the current humanitarian system is established. And you can agree whether it's right, wrong, or different. That's fine. The question has to be, how do you deal then with people who do not fit, who may have needs and may still be in insecure areas, affected or secondary effects of the humanitarian crisis that are not being captured within the humanitarian response plan? This is where you need to look for some creativity around alternative funding sources, or again, I would come back to the many societies, civil society organizations who support and work with whether it's patients with diabetes or other NCDs, and how those links, because those national societies or entities have links with potential funding opportunities that we will never have as an international community. Now, in terms of the health cluster, 2/3 of our partners are either national or local partners. The international partners are a small group. So maybe this is part of the dialogue around localization that we're having, is saying, how do we further capitalize and leverage on the presence, knowledge, and community engagement with NCD affected communities to create links with other funding sources in the country itself. Where's the private sector in this? You know, if you're looking for alternative funding, then let's be broad about it. You can still coalesce around an integrated approach, whether it's through the national program or indeed through some of the humanitarian delivery. But you need to think out of the box, because as Austin said, the way the current humanitarian box is shaped and also being funded is increasingly restrictive and not meeting all the needs that are there. So again, some creativity of how others already on the ground, the existing connections with access to alternative funding sources, maybe.
That's great, Linda. Thank you. And I endorse what you said, including mention of the private sector. But I want to throw in not as a disagreement, but because I know you know this very well, we have to be aware that when people are seeking private care, it can often be poor quality and impoverishing because of out-of-pocket payments. So just that's not to disagree with anything you said, but just as part of our thinking about the role of the private sector and what is on offer to people. So with that sort of extraneous comment, let me turn to Saeed if he is with us. No, not at the moment. Okay, well, we're thinking of you, Saeed. Come back if you can. Sonia, over to you.
Sorry, could
You-
you just repeat the question?
Probably not, but I can make up another one really quickly.
Okay.
Um,
Well, I can
sorry,
talk a
caught
little
you
bit about
unawares.
yeah, no, I can talk a little bit about the verticality. I mean, I think I agree with a lot of what Austin was saying. You know, I think the where to begin? I mean, I think that yes, global health and development programs do have vertical approach to programming. Like, we do see specific pots of funding for immunizations, for instance, through Gavi, or specific pots of funding for malaria. What we have in the U.S. For USAID, State Department, and CDC, which is the Presidential Malaria Initiative, or PMI. And I think that's largely because, as we have been saying, that global health or development programs are looking to build and support a health system. Humanitarian programs are not designed to build a health system or to support, like, strengthen a health system. We're there to support, and I know it's a semantics on words, but it really is support what is existing to try and bolster it to provide immediate life-saving care. And I think to that end, we do try and, like I said, it isn't parceled out funding. Like, there's a separate stream of funding for maternal and child health and humanitarian. That just isn't there, because we really want to meet what is most needed on the ground, in the country, in the context. And we do try and integrate those sectors. We try and integrate health and WASH and nutrition and protection, which is really important. And I think, that there are other elements of things that are happening in a humanitarian context that we have to be aware of. There are tough choices, and we're not going to have a single stream of funding just for clinical management or rape for gender-based violence survivors, right? It's going to be incorporated into an intersectoral approach, because we need our partners who are working in protection, who are working in health, who are working in cash. So I think that it's probably not as vertical and humanitarian as maybe it seems. But I do think if you're looking at a larger question, like, should we have something like a Gavi or something like, that's specific for NCD care, I think that goes back to the issue that those largely work through governments. And humanitarian actors cannot access that funding for a variety of reasons. One of them is because often, like I mentioned, where we are working, governments are party to the conflict, and they may not want those services to be in those specific locations. And we saw this with COVID. So, there's setting up a separate fund, I think, would be, I agree. I don't think it would be beneficial if you're trying to look at what humanitarians are trying to do on the ground. But yeah, I mean, I think that the Global Fund actually has done quite well in bringing in the humanitarian community. I mean, they have really integrated well in figuring out how to support humanitarian partners on the ground to deliver, malaria, TB, HIV, and they have really worked through the cluster. And I think that's an important point, is that these actions require coordination and work through the health cluster and the cluster partners. And if you're trying to work outside that system, it's not going to work. I'll stop there. Thanks.
Thank you, Sonia. So I hereby take off the table the separate vertical fund for NCDs or NCDs in humanitarian settings. Consider it dead. Because in fact, it's not talked about at all in the NCD world. But you brought up, I think, a really important example. And I guess I want to, for a moment, come back to you before we move on and explore the parameters of what you brought up, which is the Global Fund and its success in integrating and including humanitarian needs within its priorities. And many people in the room, I'm sure, know that the Global Fund is open to NCD needs as well, applications that include NCD needs. That's relatively new. It didn't happen for many years, but it's real now. And in fact, the Global Financing Facility at the World Bank, which is oriented towards maternal and child care, of course, is also exploring the parameters around what it ought to be doing related to NCDs. So I guess I'm just wondering whether you sort of see that as progress and something that, within the cluster approach or the HR, I'm going to get wrong, whatever, the clusters, is that something that makes sense? Let me be really specific, like, children with type 1 or a woman with gestational diabetes who's getting ready to deliver. Are those moments that fit within the maternal and child health priorities that often bubble to the top or are at the top? Is that a very clear question?
Yes, but I'm not sure if you want me to answer it now, or did you want to wait until you
I'm
talk to the
happy
other
to have you give
panelists?
a reaction now. Yeah, no, I it's a dialogue.
I mean, I guess I would it depends. I think it's the needs of what is the context on the ground. I don't think we can make a blanket statement. I think it depends on what are the cluster partners seeing that bubble up to the top in terms of, uh, maternal and child care. And those are the things that should take priority. I look, my experience is this. I will not comment on what's happening within a country unless I am there and I am doing the work. My experience is that the people that are working in that country know better what the needs are than me sitting in Washington, D.C. In my experience, bringing in something that's not NCDs, but Ebola, is that, while we were working in country and I was with Laura, a lot of people outside of that country had a lot of recommendations and advice and were quite critical of what we were doing in country. And, I hesitate to make that same statement because I know what it's like when you're there and you're working and you're faced with enormous challenges. And so for me to sit here and say, these are the needs and this is what you should do, this is how you should prioritize your limited funding, I don't think is the way I would go, but I would look to the health cluster partners to say to me, these are the needs. We are seeing women with gestational diabetes that need help. And those are the priorities. That's where I would look to. So I would say that those are that depends.
Thank you. Thank you. I mean, I think that's a very, very ethical response. Just that's my personal view from a donor standpoint. Let me turn to you, Laura, before Austin, and you may want to address some aspect of that question because you just told us that's what you folks are trying to do as well. But over to you.
Yeah, I mean, so I think on a very practical level, what this looks like is BHA, right, which Sonia leads. BHA gives us $1 million for 5 health facilities in Somalia, right? So we have $1 million, and I don't know if anybody here is familiar with Somalia. Talk about access issues. It's a very, very, very hard place to make sure that we are able to access all of the health facilities. So teams put together a budget, they put together a program plan, and usually, almost always, the medicine list, right, is going to be like they put together a medicine list and it's $300,000, but actually the budget line is only $150,000. So where these practical decisions come in is they're going to reduce the metformin before they reduce the oxytocin. That's where that's how, right? So yes, yes, we hope like women should be screened for gestational diabetes, and the ones who have gestational diabetes, we hope that they're on medication. But it's about which drugs are gonna be out of stock first, right? If that helps to kind of like understand just like the practical decision making that people have, like which clinical topics are we going to pay for trainings for, right? What are we going to prioritize for community health workers, right? So those are the types of things that I think that's like how in practice we do what a lot of yeah, these types of practical kind of choices that we have to make. That helps kind of give an example of what it actually looks like.
I'm going to throw out another question and then turn to Austin. And this is on that exact point, because it's to me reminiscent of the earlier days of HIV and AIDS when drugs began to be available and all we heard about all the time was stockouts. And so clearly there were supply chain issues and procurement issues and so on, even though the drugs were cheap. So I'm going to throw it out to anybody that wants to come back to that when we go to Q&A, which we will in a couple of moments. And James, I'm looking at you because I know that you have that background. So,
Okay.
Austin.
So you wanted more less of a rant and more practical things from me. So I think the first thing I'd say is so NORAD is not a humanitarian donor, or hasn't been. Our humanitarian financing has come out of the Ministry of Foreign Affairs and not even under the development section, under the political section. It's now being moved over to NORAD. So God knows. But generally speaking, humanitarian donors don't have any technical view or policy at all. So, or at least in Norway and probably most of Europe. But what we would need to know, so first of all, I think, the UNRWA example is perfect. 6,482 people on diabetic care beforehand, and they could track them, and they got 62% of them. There is a very strong argument, humanitarian argument to be made, that if people are on care, that they should be supported immediately afterwards. It's not the same public health argument as being in the top 10, but there is a strong humanitarian argument to be made. The second point is technology. So I, for a short while, was coordinator for UNICEF, and I'm surprised UNICEF hasn't come up today at all. UNICEF Supplies is the major humanitarian supply source, and they do stock insulin and things. So I would like to hear a little bit from them. But so I ran all of the health centers in Somalia, all 3 areas of Somalia, and then you had MSF, but you also had small Somali organizations and the different level of feasibility. So technology-wise, are we talking about a program that only MSF can run or ICRC can run in a big hospital, or are we talking about a ability to screen and treat or maintain treatment? Because if you're arguing that all of these people were on care, there's no way that one agency can do it. You have to have an equitable response, right? So that's the second one. Can we have a feasible and equitable response to this problem? The third one is exit. Any humanitarian donor is going to want to know, when does the money have to stop? And the problem is we always think, oh, it will go back to the public sector. But much of this is done in the private sector. How do you exit when people have been seeking care in the private sector, not with public support? So those 3 things, I think, are really critical. If we can get those 3 things, and the technology means bringing the price down, but also the simplicity down, no cold chain, pens sound much easier. I don't care whether they're really, brilliant. They just sound easier. Cheap pens, no cold chain, anyone can do it. And then the peer group stuff, that's not so high technology. Then yeah, maybe we can have it in every single thing, so that when there is the just reason to do a diabetes response, it can be done. My problem now is I don't think we're going to do a diabetes response in every situation, and I doubt we can do it in most. So we got to get closer to that. We got to know when we're going to do it, and we got to be able to do it when we're going to do it. And it's got to be cheaper and easier, and it's got to be more equitable, and we've got to know how to get out of it. There you go.
I think he's done a beautiful job of teeing up a discussion, don't you? If anybody, we're going to turn to Q&A. If anybody wants to raise their hand right off the bat to disagree with him, you can agree if you want, but disagreement's more fun. Let's hear from folks in the audience. Reactions, also questions, and also on screen if you want to put your hands up for any comments and feedback, but we'll certainly be coming to you for responses as well, Linda and Sonia, as much as you can stay with us. Yes, sir.
Yeah, good afternoon. My name is Apostolos Veis. I'm a medical doctor. It happened also in my life to work for MSF also.
Shame on you.
Shame on me. So currently I work for an organization called Intersos here in Greece, and we work with people on the move and people stranded. So I love the discussion going on overall. I like the title, and if you go back to the panel title, it's an interesting point to talk about NCDs in humanitarian crisis. The question at the moment is that following the discussions in Denmark about WHO, UNHCR, and people on the move and NCDs and all this stuff, we are forgetting just a small thing. I mean, we said before that NCDs are not public health or diabetes is not public health. They are public health. So I think it's a matter of mentioning it and talking about it and presenting it properly. Now, the issues that we're seeing around lacking of funds, not proper tools in place, not proper diagnostics, etc., I don't think it's something new. And I think there are around here in this room a lot of MSF access campaigns. So I think they have, I think there are some. Yeah, there are many of them. So I think so I think we are repeating ourselves in a certain point. Now, the question that is coming a bit more challenging, and I'll bring it back to you, is the following. We are living in a context considered to be a developed world. I mean, you are in a country considered to be a member of European Union. In reality, it's not. It is the second poorest country in Europe. Majority 2.6 million people are at that poverty line. People are not accessing medication of non-communicable diseases. The government is giving 500 million to the pharmaceutical companies to produce medication because they say it's not profitable. So in reality, there's no money funds to give to NGOs anymore. The big foundations are being told by economists that the Greece and Europe is developing very well economically, so no need for NGOs. So no funds for that direction. So give funds for integration. What's integration? It's bullshit. Sorry for that. So I think for me the discussion is to come back again to the basic principles. When you talk about NCDs and humanitarian crisis, no, we have to talk about NCDs and people. Finished. My mother doesn't have access to her treatment of NCDs. And if I tell her about people of humanitarian crisis or people fleeing, climate change and all this stuff, she says, "What about me?" I mean, so reality today, we talk about all those needs. And I think in 2012, when Greece was going through a big economical crisis, I at the time was working for MSF. I had to tell them that you can use generics. We are using generics. And that time, the medical community was saying generics kills. We cannot use generics. And then, of course, the country entered into generics by definition, and generics are nice, and the people are used to all this stuff. So I think we're repeating ourselves on certain things. I think definitely we could have cheaper products, but I think the discussion at the moment, to my feeling and to my point is that we're going into wrong discussion. We're repeating the same topic and the same discussion to convince the pharma to produce something cheaper, to convince the government to give money. No, I think the responsibility for people on the move, responsibility for people who are etc., is a state responsibility. I think we need to give the ball on the right decision, and we don't have to close access campaign. We need to have a bigger access campaign with a bigger voice. No, but that's what reality is about. Because theoretically, the access campaign is the one who give an example. What is the reality? What is the cost? And what needs to be done? The reality is there. If the government don't want to buy it, and COVID was an example on that. I understand that business, Austin, don't get me wrong. I know that business is business and will continue to be a business. And business was a priority before the human's life. That's clear. But I think as humanitarian people, as medical people, as people working on the field, I think we know what the story is about. So for me, I think diabetes management is the same like malnutrition. It's the same like pneumonia. It's the same. I think they have the same problematic in diagnosis. If we want to arrange them, who is first and who is second, I think this is wrong. Who is second and who is first? I think this is an important thing that we have to decide about lives of people. And we may have to make the choice. Me as a medical doctor, I'll make the choice on the patient needs. You will not tell me if it's an NCD, it's a development or it's not development, and all this stuff. So anyway, to make it short, I think we need to bring the discussion back on access campaign on 1999. That is what we need to bring the discussion. And I think we need to convince my mother and the community that are going to vote in European elections about what the situation is about. And all these fears about that the ultra-right is taking power and the right governments and all this stuff, this is again for consumption. Because we don't take time, we are talking to each other here, and all of us were converted. I mean, we don't need to convince each other, or we may disagree on something, but we'll have a beer later on and we'll agree on that. The question is, can we go out of this room? Academia to take their papers of Lancet and JAMA to my mother to make it in a simple way, to understand a bit. Because if the people, they don't understand what the problem is about, they will not support whatever ideas you tell. Because at the end of the story, everybody is put under two big questions. Economic crisis, no money, food crisis, inflation. So guys, don't talk about those crises, NCDs and diabetes. Forget Gaza and the rest of the people. Thank you very much.
Thank you. Thank you. There's a lot there. And I think I agree. I think for me, the big message is we need to leave this room with something to do, a sense of purpose, and a sense of community that we're going to go out there and do it. Thank you very much. Okay. Does anybody want to react or we go back to the audience? I want to give you a chance if you'd like, because I get to anyway. Okay. Let's go. Yeah. Back. Yes. Doctor. Oh, sorry. And introduce yourself and hold it up close, please.
It's working now.
There we go.
I just want to say that I'm talking about a forgotten crisis, which is Myanmar. And actually, you can ally with people living with HIV. All chronic disease patients who are losing access are systematically losing access. And to all the funders out here, you can, whether it's TB or HIV, people on treatment, whether it's hypertension or diabetes, they're losing access. And when the emergency kits are ordered or, the emergency response is done, chronic diseases is kept out of the so you, of course, you prepare for cholera, you prepare for malaria, you prepare for severe acute malnutrition, you prepare for maternal and reproductive health care, but you do not look at chronic diseases. And that's my experience of actually working with MSF on the borders of India and Myanmar thing. So actually alliances should be built with people living with HIV and all the diseases who lose access in a humanitarian crisis. So I just wanted to sort of highlight that if we are asking funders and humanitarian actors to do what they need to do, then we need to build that alliance and intersectionality with other chronic diseases. A person living with HIV, the networks, the global network of positive people will absolutely ally with people who are asking for diabetes care in humanitarian settings because that's the experience of people living with HIV. So I just wanted to say this, that the harsh reality is we are preparing for certain crises in a particular way and not looking at the forgotten crisis on chronic diseases. So the HIV/AIDS crisis is not over. We're just seeing a resurgence. We'll see a resurgence of AIDS on in Myanmar due to the crisis over there. So that's the reality. Yeah.
Thank you. But we did learn a lot from it, and we need to bring up those lessons. So I think over here, sorry, I skipped you before.
Oh, it's all good. All right, so I'm James, a person living with type 1 diabetes. I'm not representing any organization here officially, but I work with one that starts with W. And I also used to work with MSF. Ooh.
Who did not work with MSF? Okay.
So I'm going to do the usual white guy thing of statement than the actual question. So the statement is I'm getting real retro vibes from a lot of what's being said. A lot of basement 2024 in Geneva, 2014 back in Geneva. You know, it's so difficult to work in conflict. It's so difficult to transport insulin. Well, Safan was doing it prior to 2014, 2012, and we just heard about Sana's experience in Pakistan. I think there's a risk for traditional funders to lose all relevancy trying to work in a country like Pakistan or trying to work in the occupied territory of Palestine and to say you don't fund diabetes work. You lose all relevancy. And also to do maternal and child health and not do gestational diabetes. That doesn't seem logical. So my question is, HIV in the 80s was considered the lifestyle disorder. If only those silly people didn't do X, Y, and Z, and they broke out of it. And traditional funders now don't dare say the same things they say about diabetes, or sorry, HIV, that they are saying still about HIV. So as funders, what does the community need to do to break out of the lifestyle trap and actually start funding things like type 1 diabetes, things like gestational diabetes, and even type 2 diabetes, especially for populations that are impacted by circumstances out of individual control? So climate change, indigenous culture being destroyed, etc. So what does the community need to do to convince the traditional funders to start funding?
Thank you. Thank you. Small question. I'm going to take a few more questions and then come to the panel. But Laura, did you want to jump?
Yeah, I just want to make sure that what I said was
Do you use the mic, please? Thanks.
yeah, I just want to make sure it's clear. There's been amazing things that have happened over the last 8 years in terms of integrating NCDs within primary healthcare, right? I just want to make sure that's clear. It's just because we haven't come far enough doesn't mean we haven't done a lot, right? So I just want to make sure we're not treating with, gestational diabetes. We're not treating people with type 1 diabetes. It's just there's a lot of needs, and what we're trying to say is that it's very hard to cover all of those needs in a comprehensive way. So I just want to make sure that it wasn't misunderstood. We have a long way to go, but we have come quite a far.
Yeah, and I thought we also said it's clear that the argument in Gaza is clear. The UNRWA argument presentation, absolutely clear, no brainer, and to a certain extent Yemen as well. But to go from very small, very important, but very small projects towards a more systemic approach, you would need information, you would need the technology, and you would need the feasible delivery, and you would need the exit strategy. That's where you go from few people doing very symbolic small projects towards a broadly integrated technology of action that can be spread across a lot of groups. But at the moment, most of the data came from a Lebanon or singular project. It's really important that we do this stuff to show it can be done. But you have to translate that technology into something that is generalizable. And it's not yet. I'm sorry.
Okay, I was hoping we could give Linda a moment for any last comments before she had to fade out, but she just beautifully and quietly faded out. So I think we don't have her. So I'd like to take a couple of more questions or comments, maybe specifically questions addressed to panelists. And we have 3 panelists there, and then we'll give them a chance to respond to whatever they want to respond to. Okay, before we close up. Yes, ma'am, over here.
Okay, it's working. So I'll just say a small statement and then ask a question. When I started advocacy, I started working from I'm a person with diabetes. I need to advocate for people with diabetes. And then I realized that it's not just people with diabetes, it's people with NCDs. And now I advocate for motherhood also. So it kind of all lives matter in a sense, and everyone needs help. And health should be something accessible with equity. A question maybe to the panel is, I come from Lebanon, where a lot of funds come in and little gets done, honestly. I've witnessed during my 33 years of existence, partially a civil war. I don't know how many Israeli wars, Daesh coming in, bombings, assassinations, you name it, complex PTSD. And so much has come into the country and nothing is done. Not even diabetes or insulin put on the essential medication list for the Ministry of Health. We don't get reimbursed for insulin. We have to wait a year to get reimbursed for a pen of insulin. I also happen to work as a full-time job at a donor organization. So I kind of understand how things work. But what can be done policy-wise to get governments to work properly? Okay, we get the money in, but how do we use the money for something sustainable that reflects onto a better future? And like with all the experience here and the academic, the policy making, the lived experience, how can we synergize to make sure money comes in and goes to actual projects that work on the long run, even after organizations leave the country? Isn't that the whole point of advocacy? To actually get to a sustainable solution?
Thank you. Wait, I'm going to come. I'm going to come to the panel after we take a few more. Mohammed, you want to add to that?
Just
briefly?
one kind of thing, just to complement with what Serena's has said. So I think when it comes to generally when it comes to public-private partnerships, and probably we've mentioned, like many panelists mentioned the example of Gavi, and how probably their work, and in my opinion, is kind of, it reflects a more extrinsic and not intrinsic way of how the private, for example, alliances, or how these alliances are working to have more power in setting global agenda when it comes to, for example, immunizations. And at the moment, maybe we're discussing NCDs and diabetes. It's also kind of the same. It this kind of extrinsic power and facilitation would definitely, yes, we agree that we need kind of more public empowerment, let's say, to governments or to any local partners that are functioning to deliver health and to provide healthcare services. But at the same time, if the way that the international bodies and the way that, for example, international alliances are working to, again, increase their let's say their work and the way they do their work to set those global images, then we will not reach that point where public governments or local partners are actually sitting or helping in setting those local agendas and then global agendas. And I think yes, advocacy is important, synergizing is important, and valuing this synergies that we try to get, as for example, people with diabetes, and we've mentioned how important it is to include people with diabetes and in anything that we do, because I think we kind of
A
a different point.
question, Mohammed?
Oh, how, again, you've mentioned how to come up with a different with again how can we value these synergies, how can we value those inequities in the way that we think towards solving a solution, whether that comes from a public-private partnership issue method, or from kind of how humanitarian organizations work to support local governments for the long, sustainable, unfragmented solution.
Okay, thank you. I want to I want to go up here to the front, then to the back. I think I was seeing the back for a while there, and then here. Can we go a little past 5 because we started a little late? Okay, so don't go away. Yes, please.
Thanks, Rachel. Thanks, everybody. I'll keep it very concise. So I'm Aveen again. I used to work for MSF, but I'm the research and data co-lead for IATA. So it's a data question. Do you feel in your roles that you have enough data on NCDs, particularly at the beginning of a crisis in the first 30 days, and then in the subsequent, protracted crises? Do you have the right kind of data? Do you have enough data, and do you have it on time?
Thank you, Adrian. So you can pick your questions. We'll come back to you. You don't have to try to remember them all. Back in the back there, please.
Tom. I won't say who I work for because it's not relevant. I think my head is spinning a bit, as I guess everyone is, with the incredible complexity of this. I think it's also a really rich discussion. I had one comment and a couple of questions. I think the comment I have is around the elephant in the room, and I think Apostolos touched on it, that diabetes is a global humanitarian crisis. It is not a crisis within humanitarian settings. And the concept of humanitarian settings is something I'm sure we all disagree on, even if we look at the actual definitions. One of the definitions that the Illuminati in MSF talk about is a humanitarian intervention is one that seeks to correct a temporary disruption in the equilibrium of healthcare. In other words, if the healthcare was there and it disappears, then you have to put it back. So by definition, the wealthier the society, the more there is to put back. And that applies very much to NCDs. If there was nothing there before, then there's nothing to put, and you don't engage with NCDs at all, with the exception of those incredibly expensive life-saving interventions, because life-saving is another of the axioms of humanitarian intervention. So if someone comes in with a diabetic emergency, you must treat it. And Austin, you referred to the moral compulsion to fill that gap in services. When somebody was on hypertensive care or diabetic care, however mild or minor their need was, you must still fill that gap when they drop out of care. And I think there is a real thing to dig into around what that actually means and what the rationale of all of this discussion is within that framing of humanitarianism. So maybe in the working groups, this will come out more. But what I was interested in terms of questions, I'd like to hear, because there are big things and there are small things. The world is getting worse, no question, funding is disappearing, and we all want a big global solution. But there are also small solutions. And I think, again, my personal belief is it lies in the community and the way we can build community as a slow push towards political interventions and social interventions. But I was interested to hear from the panel, and maybe you were going to ask anyway, do they have a practical small solution and a practical big solution, which I doubt? And I just one other question to Austin, because he was so against the idea of pooled procurement. We clearly need some mechanism to ensure that the lowest cost, quality, simple products are available as widely as possible. That's what pooled procurement is about. If that's not the solution, then what would be better? Thanks.
Great. Thank you. There is a PAHO regional pool procurement. Yeah, just so everybody knows. So one last one is it, Seta, did you want to, and then, yeah, okay, short, and then we'll come back to our panel.
It's working? Thank you very much. Firstly, I was thinking twice, 3 times, should I raise voice or not? Because it's itself is a challenge. But firstly, thanks to Norway, you just continue to funding to us. I think it's great to us. Okay. No, it's not you, but I appreciate your minister. But anyway, the question is that I just want to be honest that yes, we are doing our best together with the health clusters, all the partners and the local and the NGOs in Gaza, but we are failing. This is the biggest failure I have ever seen in my life. We've been going there and the people are still killed and people are still moving. That one of my colleagues that communicated Rafa yesterday told me that why the world, when the world start recognizing us human beings, that's very honest, and I couldn't answer anything. And so that, of course, that I don't want to be beaten, so that I will continue the way we can do in the very limited this space we have. And for example, that I'm not allowed to do the press conference anymore because of the many different issues. But still, we want to publish papers. We want to do things that we can tell that we're not beaten. But the question to you is that I think the world is totally different, or broken, or bipolar, multipolar, and you have an election this year in many parts of Europe. Good luck. And we have a very big election in the United States. Please, good luck. And then so it's in the changing environment, and then so I just want to ask you a very simple question: why we are failing such miserably in Gaza, from your point of view? Why? Why the world allowing this to happen? And then why that it still continues and the war never ends? So what do you think? Sorry.
Thank.
Huh?
Yeah, I'm. Thank you, Seta. You're a hero, and I think I'm going to let our panelists off the hook on answering that question, if you don't mind. Last
Can
point,
I
really
thank you
briefly.
so much for allowing us to go in. So I wanted to just bring attention to, because a lot of what you have said just made me think. And I'm sorry, sir, I missed your name, but what you were saying about um, the whole thing, I'll just try to wrap it up in 1 or 2 sentences. So last year in Pakistan, we had, apart from all the humanitarian crises that we are defining here, war, natural, etc., 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 there's one more crisis that we're probably not paying attention to, and that's the crisis of shortages. And that's global. And it's more prominent in low and middle income countries. So last year, last 1.5 years in Pakistan, there was a huge economic and political crisis. Lilly wrapped up its functions from Pakistan. Sanofi was sold to a local businessman, a business company, and they're doing the the business there. The only company left right now is Novo Nordisk. The other two wrapped up, and there is a consistent ongoing shortages that come in. For example, one insulin will go off the shelves, then another one will go off the shelf because there's so for example, people are shifting from Humalog to Novo Nordisk as Novo Rapid, and then Novo Rapid will go short because there's a difference between the demand and the supply. And to the best of my belief, these shortages are being created for price increase. While I do understand that these businesses do need some price increase because of the USD rate inflation that has gone up, but at the same time, we do need to hold both the governments and the companies responsible and accountable for this, that they can't arm twist like this for price increase, and the government's responsible as well, that they need to respond to the situation well in time instead of letting it go to the level where shortage is created after one after another. Three shortage cycles, the last one started in December, it's continuing till date. And yes, I agree, we need to hold the governments accountable. It's not just the role of the humanitarian organizations. The governments need to be held accountable for all these crises that are happening.
Thank you. Thank you. I don't think that was the question, but it was a forceful comment. Thank you. So I'm going to turn to the panelists for final words, comments, answers, and then I'm going to wrap up so we're not too late. Sonia, please, would you like to go first?
Sure. What can I say? I think basically, okay. I think that there's a lot here for what comes between humanitarian and what comes, between humanitarian development. And we talk about the nexus, and I'm be the first one to say, I don't know what the nexus is. I think all of us define it very differently. Some of us who have been in this field for a long time remember the term used to be relief to development, and now it's the nexus. And so I think if we actually had a definition of the nexus that we all understood and agreed to, and that was standardized, maybe we'd have a bit more understanding of what it is. But and I say this because I think there's a lot that's put on humanitarians right now. And we can't do everything. And I think, Laura and Linda made really good points about priorities and how those priorities are determined. And, what are we held accountable for when crises are increasing? Our access is getting further and further difficult and limited. There are attacks on healthcare workers that happen all the time. We are still trying to do our best to integrate, all of these complex issues within primary healthcare to deliver services. Humanitarians are working around the clock. So I think, how can we leverage some of the other donors, like development donors, non-traditional donors, to do some of this work that is outside of our wheelhouse, like building systems within governments? I think that would be really appreciated. It is unfair, I think, to hold humanitarians accountable for everything. So I'll stop there. Thank you.
Thank you. That's, I think, something we'll take into our workshop tomorrow. A great question. Thank you, Sonia. Who wants to go first? Oh, Saeed is back. Yeah. Saeed, we missed you, but if you can hear us, we'd love to hear any last comments from you. I don't know if you heard the questions from the audience, but really just share with us what you think we should be thinking about as in our day 2 tomorrow.
Do you speak to me?
Yes, I'm speaking to you.
Yeah, it's very bad. They have very bad internet connection. Thankfully, I hear the last discussions and comment. So I want to discuss more about it, but I agree with much of what has been said here. And let's be honest, we talk about NCDs. The first step was to integrate it. in the primary healthcare system, minimum service package. I think that the donor and international organization should also enable the government and the local communities to play its part. Yes, this a very difficult way to describe how it should be, especially in countries like Yemen. There is no continuous peace, no peace war, but it should be a way that we should at some point, uh, you know, have independence and deal with our own problem. So I think building the systems, and especially related to NCDs and governments and all the communities, is one of the most important things to consider, whether in short term or in long terms. Also, innovative, practical solutions, whether short or long terms, is highly appreciated, especially in countries like Yemen. So all of this should be combined and organized. Every country is different from others, but I think all countries should make progress in cities. Who will tell in 90s that major cause of death in Yemen will be NCDs? We spoke about infectious disease, spoke about accidents, and now we are speaking about the NCD. It's global trend. This will only keep getting worse. And the NCD is one of the biggest. It's not the biggest problem. Also, it's a hindering of development. You cannot ask for sustainable development without having a healthy people to do this. So it's really difficult. We should go involve ideas and innovations every level. We should also encourage, small project, small solution, whether it's short term, intermediate term, should be encouraged. So I think building systems and having a good management system at central and at periphery of the country should be a thing. It's the first step. You cannot work without a system. You cannot work without a policy. You cannot work without a guideline. You cannot work without a guideline. This is a problem in Yemen. So when the first came, there is no actual data system. We could speak about diabetic patients, and we say, okay, we need 400 to become mixed card or something like that, or 100,000. But this is not based on evidence on how much we actually need. So now we are integrating systems like HIs, include NCDs, and we want to track. It's a slow process, but I think all we should start at some point. So that's my idea, starting whether small or big, and I think this is the most important point to consider right now, especially for NCDs.
Thank you. Thank you very much. Practical solutions and tracking, getting data. Thank you, Saeed. Over to Laura and then Austin.
Great, thanks. So I think that in order to kind of meet the challenge that has been outlined here, we need to kind of try to reduce the cost of care and improve the quality, right? And I think the way to decrease the cost is to do some sort of a, I don't know what it is, but something to drive down the cost of medicines and diagnostics. There's many people in this room who are much more informed about how to do that than I am, but that's what's going to really make the big difference from cost. And then I think from a quality perspective, I think we need to use tools that we already have, things like PenH, right? That make that that have algorithmic kind of clinical protocols more easily accessible. I think that that can really do a lot to improve the quality of care. And then, of course, everything that was, more of like the peer-to-peer work and more of actually working directly with people living with these conditions. So I think those are the things that we can do. I think investing in those types of solutions is the only thing that's going to make a difference. Um, but we have to drive down the cost of care. Otherwise, we're just never going to be able to meet the needs. So, yeah.
That applies to the humanitarian situation of the US as well, just for the record. Everywhere. Austin?
So there are quite a lot of questions. So I'll try and, I think, to the position by the Greek gentleman who works for Intersos, doctor. So, it was a beautiful statement, but it for me, that was a citizen statement, not a public employee statement. Okay, and I think this is part of my answer to you guys over there. You've got this yearning for positive change, but you have to differentiate between a citizen and its government, the community of states and their responsibility, and then external independent actors. And they all have very different power and they all have very different political meaning. But in the current political world that we live in, the only way you can get a good government is if your citizens hold your government to account. It cannot be imposed from outside, even by America. And America's losing the will to try, which is probably a good thing. So I'm afraid I can't tell you how we can turn our meager investments into an effective and accountable and fair state. I'm afraid that's up to the Lebanese people. I know that there are in lot. Okay. Do you want us to stop putting money? Do you want us to stop? Do you want all aid to stop? Would that make? Hmm? Right. 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 Yeah. Okay. I get your point. Yeah. Yes, that is a very serious point. Donors should be holding governments they provide money with or lend money with to account for those. I agree. They do try a bit, but the problem is what we're shining the light on is the better part, the more scrutinized, the more accountable aid. We do huge evaluations on small medical programs, but we don't do much on multi-million state support programs. But anyway, we can talk a bit more about it afterwards. But I do think, yeah, Tom, you can characterize diabetes as a global humanitarian crisis if you like. That's fine. I don't think the kind of humanitarian response that we're talking about here, agencies, is the right or complete response to such a crisis. So we work and try, and I can talk more about that another time, about financing NCDs more broadly. And I tell you that most of the countries where we finally get finance for NCDs, it goes disastrously wrong because we put in the wrong incentives and we drive towards high-end clinical care, high-end treatment. It's inequitable, it's ineffective, and it's going to compound the economic disaster of NCD wave rather than help it. But it has to be done, and it has to be done on multiple fronts. I don't personally think characterizing it as a humanitarian crisis is going to elicit the right kind of response. Personally, we can talk about that. It is a very serious challenge, both economically and health-wise, and we have to do something about it. Technology does matter. If you look at graphs about child survival today compared to 100 years ago, we are way better at lower costs because of and the impact of technology is as big as the impact on GDP growth. It really does matter. But we also have to talk about the technologies of intervention and the public policy. You can't just put in good vaccines or tech without proper public policy and proper public systems of delivery. And I think that the humanitarian agencies could have better algorithmic treatments where they could say, okay, in this setting, we can do this with this access and these delivery conditions, we can do this. We can do these screenings, these diagnostics, this kind of treatment. And in better situations, we can do more. So moving towards algorithmic care with a very reduced number of products and then spreading it out over all the agencies that can handle that intervention, that is important work. I would say that you might want to consider a sort of Nansen passport for chronic care. So that everyone in the world not in crisis or not in crisis, would have some kind of passport about chronic care, so that when they move, they carry with them some kind of record about what they're getting and where to go. And that might be an advance. And that's sort of getting to data. I think one of the big data problems, and yes, Tom, I pointed out the biggest problem is equality. If everyone had healthcare systems equal, then crisis would be like that. They don't. And so it does mean that we're doing diabetes in Lebanon, but we're not doing it in Central African Republic. We're not doing it in Darfur, right? So the data problem is that we don't know what we don't know, someone said earlier, in a large part of the world. And so that's one problem. The second problem, where we have data, where we do know what we know, there are these delivery technology problems, these process problems that create some data needs that need sorting out to make it normal. What do I think about pool procurement? I think it's a good thing, Tom. I think it should be for citizens and governments, not for donors and international Geneva-based agencies. I think you have to be very careful how you aggregate pools of demand and be wary of over-aggregating till you break down the collective partnership that is involved in a pool procurement fund or PON. I think PAHA has troubles. The Caribbean and East Caribbean one didn't work. The GMC in Middle East didn't work. The SADC one didn't work. There are lots of problems with regional pool funds. We always pull up PAHO as a positive one, but there are so many failures. But I mean, certainly that's one of the things we were trying to work with Tom Frieden's group, Save the Heart's group.
Resolve.
Was okay, you've gotten large numbers of patients on treatment, you've got algorithmic care, can we boil this down into some kind of pooling of procurement? So I worked with another one of you guys, Jennifer Cohen, a lot on that, right? For years I worked with her because she wanted a big fund as well. So there are things, positive, practical things we can do about procurement and pooling around data that travels with people, around interventions or technologies at the commodity level, but also at the procedure level. But the bigger questions about aren't we failing in Gaza and what do we do about the crisis of governance in Lebanon, I'm going to leave to Rachel for the closing remarks.
Perfect. Thank you. As you can see, we're going to have a really good discussion in the workshop tomorrow. So you're all welcome to join us. I'm going to take the chair's prerogative of closing us up with a few thoughts learned from a long journey on NCDs, because I think a lot of it implies. Just 5 key lessons. I'll be quick. One is the need to demystify the story and the needs. I think it's taken us a long time with NCDs, but we're getting there. The second one is simplifying the tasks and having cost and benefit information available. I think that echoes Laura especially. That's really important. And maybe there's some of that, but not enough. Having strong advocacy from those with lived experience, that was very impressive today. You're far and away faster than the NCD community on that point. Hammering away at the equity and moral arguments, I think you're on the right track there. It's certainly there, and I'm hearing it today. And quickly developing case studies or examples of success. Failure too is important, but success, and I'm not hearing enough of that, that's not a criticism at all. It's just, here's my perspective as kind of an outsider. So those are some lessons that we've learned in the NCD community that I think may be relevant, but most importantly, financing isn't just the money. It's about being efficient. It's about partnering. It's about knowing what you can affect and not trying to boil the ocean, as it were, and talking the right language with the right people. And I think we're getting there. This is very helpful. Thank you to the panelists very much. Really, really rich, really informative. And we hope to keep discussing this with all of you. Let's thank them. Thank you.
So before everyone we round up and everyone goes out to get a much deserved drink, I which could be alcoholic or non-alcoholic. I wasn't implying it should be alcoholic. I just want to I want to wrap up with a few final words for today. As was just said, in fact, I think the workshops tomorrow are very well lined up to pick up on some of these discussions, including some of the last challenges that were raised around minimum service packages and some of the data and information requirements that would facilitate not only the delivery of services, but also making realistic proposals to donors. So please do participate in those workshops. We hope they will be very action oriented and will actually lead us to a set of priorities to work on over the coming year. I'm struck by so many things from today, and that last session contained a lot of provocations, which are very helpful to drive the discussions tomorrow. Just want to highlight a couple of points from my side that we talked, as we often do, about the centrality of people living with diabetes in humanitarian action. It was very clear today to me the way that people's social networks, and I don't mean their Facebook networks, I mean they're what we used to refer to as social networks, the network within which people live, play an absolutely critical role, not just in terms of peer support, but also enabling access to medication and equipment and advocacy. I think I have to be honest that even I would say within WHO, but also with other agencies I've worked with, I would say that we still regard, whether we call it community protection, community engagement, or community participation, we regard it as an enabler for service delivery, first and foremost. And I think that what this discussion point reminded me of is that actually this is sort of the bedrock. I mean, the community networks are the bedrock. They are what is sustaining care for people throughout recurrent periods of insecurity, periods of crisis. As humanitarian medical actors, should we be thinking primarily that should be the entry point? How can we support those community services? And then how could the health services that we focus on, how could they be positioned around this bedrock of community support instead of the other way around? And of course, there are organizations, including the IFRC, that probably take a point of entry that's closer to that. I think the point about NCDs in humanitarian settings not being synonymous with NCDs in emergencies, and in fact, all of us differing in terms of how we see humanitarian settings, I was struck by the comment, there is no nexus. I think that fits with what I have seen through a landscaping review we carried out within WHO of integration of NCDs in response to humanitarian emergencies in the last 5 years. And we looked at 30 different humanitarian emergencies and did 8 in-depth case studies. And what we saw there is that, in fact, NCDs are often included in the HRP, in the humanitarian response plan. But when that funding runs out, the NCD activities that were initiated as part of that plan are not sustained usually. And the reality in humanitarian settings is that in the majority of countries, a substantial proportion of funding for NCD care in that setting was never from the HRP. It was never through humanitarian mechanisms. It was always through repurposing of long-term development funding. So the fact is, how do you blend these things together? How do you blend these financial sources together so that the promising pilot projects don't just fold at the end of the HRP cycle? And because they're actually being delivered by the same people, they're being delivered by Ministry of Health Services supported by different implementing partners, but consistently they collapse at the end of the HRP cycle. And I think I'm not saying that's a problem only for the donors to sit together to think about, but I mean, as was said, I mean, the minimum service package, other and cost reduction strategies are clearly part of that puzzle. Finally, I just want to highlight, many times today it was this. I felt we were looking at that issue of NCDs as chronic diseases, and I've always found that conceptually difficult, because I once worked for an organization that begins with M, ends in F, and when when I remember we never treated NCDs as chronic diseases to begin with. In fact, we didn't treat chronic diseases. And I remember in Somalia seeing the same young girl 3 times, each time in DKA, because we treated emergencies. We didn't treat chronic diseases. So we would treat DKA and then we would send her home and we'd wait for her to come back. That has changed to some extent, but we would provide care for those emergencies, those acute conditions. We would do cesareans for women presenting in obstructed labor with macrosomic babies, but we wouldn't provide insulin on an outpatient basis. And it took 3 times of that girl coming in with DKA before we started to secretly give her insulin to take home, to keep at home. So we treated emergencies, we provided life-saving care, but we weren't treating people to stop them going blind. We weren't treating people to prevent disability, and we weren't thinking about suffering and dignity. And yet it was said today that life-saving care remains the core criterion for funders to look at NCDs. I think Sonia mentioned that a couple of times. So if that's the case, if we're considering humanitarian care, humanitarian medical action as about life-saving care, and we haven't integrated reduction of suffering and dignity into that, then I agree, we wouldn't be treating NCDs on an outpatient basis. We would still just be doing that hospital care. But the fact is that humanitarian healthcare for me includes those 2 things, includes those 3 things. It covers the emergency life-saving care, it covers restoring dignity, it covers reducing suffering. And I think this for me is a central argument for continuing to provide care for NCDs in humanitarian settings. Let's not be trapped into thinking just about emergency life-saving care, because then we'll forget part of the what is compelling us to do this work. I'm going to wrap up there. Thank you very much for joining us for today. Are there any admin points? Great. Well, thanks very much, and thanks to the online audience for joining us.